let's turn to the more provocative and potentially practice-changing findings in lung cancer from ASCO 2021. And the first I'd like to cover is in the setting of early-stage, potentially curable non-small cell lung cancer, a study called Empower 010 that was presented by Dr. Heather Wakeley. And this is a randomized phase 3 study that tested immunotherapy in the adjuvant setting. It was for patients with stage 1B to 3A disease who had undergone potentially curative resection and could be any degree of PD-L1 expression from less than 1% to high. And then patients had to have received some platinum-based chemotherapy up to 4 cycles, but anything from 1 to 4 cycles was potentially acceptable if patients discontinued early. And then patients were randomized at that point to either subsequent surveillance and supportive care, or in a 1-to-1 fashion were randomized to every 3-week atezolizumab immunotherapy for essentially up to a year, or 16 treatments, 48 weeks. And about a little over 1,000 patients ended up randomized to the immunotherapy or surveillance. And the primary endpoint was disease-free survival. And this was a hierarchical statistical design. So the way it was done was starting with an analysis just of patients with stage 2 or 3A disease and with PD-L1 expression of 1% or higher. If disease-free survival was a significant difference, then there was a subsequent analysis for any PD-L1 expression, stage 2 to 3A. And then if that analysis is positive, there was an analysis of any PD-L1 and stage 1B to 3A, so the intent to treat population. If all of those conditions were met, there was a subsequent analysis for overall survival. And what the trial demonstrated was an improvement in disease-free survival with the first analysis of PD-L1 positive disease, stage 2 and 3A. And the trial also was positive, but less so for any PD-L1 expression, stage 2 to 3A. The hazard ratio went from about, I believe, 0.66 in the initial more restricted analysis to 0.79 for the broader population with any PD-L1. And there was a subset analysis of the any PD-L1 in the stage 2 to 3A that showed that the benefit was really very concentrated in patients with high tumor PD-L1 expression. So 50% or higher had a hazard ratio of 0.43, but the any PD-L1 population but the PD-L1 1% or higher was 0.66. And so that included the patients with high PD-L1. What we can conclude from that is that the patients with low PD-L1, 1 to 49%, must be quite a bit less impressive, with a hazard ratio over 0.8, because they're essentially diluting the much more impressive improvement in disease-free survival seen in the narrower population with high PD-L1. There was also then a subsequent analysis of the intent to treat population with any PD-L1 expression and stage 1B to 3A disease, and that did not achieve statistical significance at the interim analysis, although the hazard ratio was not that different. It was 0.81 for disease-free survival. But because that did not achieve statistical significance, there was not a subsequent analysis of overall survival, and we may never get that. The side effect profile was not unexpected. It was not especially high, but it is notable that patients with who get adjuvant immunotherapy can have long-term, even potentially permanent adverse effects from this. So it's not something that we should minimize. Nevertheless, the trial was positive for a disease-free survival benefit in at least patients with stage 2 to 3A disease and with PD-L1 expression of 1% or higher. Now, that was actually clearly driven by the high PD-L1 group, but I expect that we'll see an FDA approval of this, very likely for the broader population. And the question is, what will we do with this? We don't have yet an overall survival difference. I think I will be quite inclined to pursue this, certainly talk about it for my patients who are eligible, and likely recommend it for my patients with high PD-L1, but be less enthusiastic about it for patients with low PD-L1. I think it's unfortunate that we have trials designed that do not necessarily report out analyses of overall survival if several conditions are not met. And I also think it's unfortunate that we have results that are presented with a kind of Russian nesting doll design that show PD-L1 high or PD-L1 1% or higher that includes and is likely driven by the high PD-L1 group, but doesn't separately show the results for the low PD-L1 setting. Let's move on. And another question is the potential role of immunotherapy in a preoperative setting. And Dr. Spicer presented the surgical outcomes for the Checkmate 816 trial that we had seen some preliminary results from at AACR this year. This trial looked at giving 3 cycles of chemotherapy with or without nivolumab added to that in patients with stage 1B to 3A disease. It previously showed at the AACR meeting, we saw that there was a really striking and significant improvement in the pathologic CR rate with the addition of the nivolumab just for 3 cycles, going from 2.2% with chemo alone to 24% with the addition of nivolumab, and the response rate by imaging improved from about 9% to 37% with the addition of nivolumab. And this is really quite impressive, but we now got from Dr. Spicer's analysis the results based on specifically the surgical outcomes. What we saw was a little more detail about pathologic CR rates, seeing that the differences were especially pronounced in the few patients with stage 1B disease. That was a minority of patients on the trial, but the difference was actually 0 in with chemo alone versus 40% in the patients with stage 1B disease. And we also saw results that showed the surgery was shorter by about 40 minutes in the patients who got immunotherapy, so no detrimental effect there. There was no difference in the time to get to surgery. Overall, there was deeper regression of the cancer on pathologic imaging, on pathologic analysis. There was more likely for patients to be able to undergo minimally invasive surgery without conversion to an open thoracotomy if they received nivolumab with the chemotherapy. This was particularly true for the patients with stage 3A disease, who we might envision to be kind of on the bubble for needing an open thoracotomy. They were also less likely, if they received nivolumab with chemotherapy preoperatively, to undergo a lobectomy rather than a pneumonectomy. There was no difference in complications. If anything, there was a decrease in the levels of pain in patients on the nivolumab arm, likely related to the less extensive surgery that was required in a subset of patients. And so overall, what we have here is further evidence to show that there's certainly no harmful clinical effects from the addition of the immunotherapy. If anything, many of the variables that we look at in surgical outcomes were more favorable, some significantly so, with the addition of immunotherapy to chemotherapy. In terms of what this means, we don't have an approval yet for preoperative chemoimmunotherapy, but we're going to see more work on this. This particular study was a phase 3 trial, 358 patients, and I think it will be helpful to see clinical outcomes like event-free survival and eventually overall survival. But these differences are very striking, and I think this, combined with the Empower 010 trial, will highlight that we are going to likely be incorporating immunotherapy more and more for patients with resectable disease. It remains to be determined what the best way to do that is going to be. Combined with chemo preoperatively, sequentially after adjuvant chemo postoperatively, and in which subsets. We don't have that analysis from Checkmate 816 in terms of which patients benefit most, but it's an exciting time. And in the future, I think we will be adding immunotherapy to more and more treatment plans in the early stage setting to improve the cure rates. But we don't yet have those clinical outcomes to say that. Let's turn to advanced stage disease. And one of the more interesting presentations was by Dr. Akinboro from the FDA. And this looked at a pooled analysis of data from FDA submissions in multiple phase 3 trials and focused on patients with stage 4 disease with 1 to 49% PD-L1 expression, and whether they had received immunotherapy alone, either pembrolizumab or nivolumab with ipilimumab, or immunotherapy with chemotherapy. And this was a comparison of the data from these aggregate trials, showing that the median progression-free survival was better for the patients with low PD-L1 who received chemoimmunotherapy. The median PFS was 7.7 months with chemoimmunotherapy versus 4.2 months for those receiving immunotherapy alone. But interestingly, there was no clear difference for patients who were 75 or older. This is not a definitive result. It is retrospective data, but we don't have a great comparison in a direct prospective fashion here. And for many of us, this confirmed what we already suspected, that immunotherapy is really not a preferred approach on its own for patients with low PD-L1, in contrast with high PD-L1 of 50% or greater. Nevertheless, the fact that a subset of patients, maybe those older, particularly maybe with marginal performance status or organ function, could do just as well and be well served by receiving immunotherapy. So still a role for judgment and individualization. In terms of targeted therapies, there was a great deal of interest and enthusiasm around new treatments for different different targets. One was looking at a target that we haven't previously had, and that's KRAS, specifically KRAS G12C mutations. Dr. Skoulidis presented abstract 9003, and this looked at the overall survival results with sotorasib, a KRAS G12C inhibitor that was just approved by the FDA in late May of 2021, so just before the meeting. And this had previously shown in a New England Journal publication a response rate of 37%. This is in significantly heavily pretreated patients with stage 4 disease. 90% had received either chemotherapy, platinum doublet chemo, or immunotherapy. In fact, 80% or so had received both. So for many of these patients, it was stage 3 or later, and the response rate was 37%. The median progression-free survival was 6.8 months in this heavily treated population, and the median overall survival was 12.5 months. What we also saw was some early information about co-mutations like TP53, STK11, and KEAP1, and these findings show that patients receiving sotorasib still had good responses really across a very broad range of clinical and molecular subgroups. There hasn't been a deep analysis of these co-mutations in other settings, so how to use this information is really going to be the subject more of future research, but I think it poses important questions. Now that we have sotorasib FDA approved and commercially available, many of us are going to want to use it not just as a late line, third line or later, but to move move it into second line and maybe even first line for a subset of our patients, we need to better clarify which ones are not benefiting from chemo, immunotherapy, or immunotherapy alone. And I think that this agent and other KRAS inhibitors are likely to really improve, change the field for a very large subset of patients. About 13% of our patients with advanced non-small cell have a KRAS G12C mutation, so really filling an unmet need here. But it is important to note that this agent is specifically for KRAS G12C, not for other KRAS mutations, G12D, G12V, et cetera, that we also may see in practice. But the field is going to move quickly here. Let's turn to EGFR mutations. And with that, we have some real hope for patients with acquired resistance to an activating EGFR mutation. Doctors Baumel and colleagues presented the results of the Chrysalis phase 1 trial of the combination of amivantamab and lazertinib. Amivantamab is a bispecific monoclonal antibody against EGFR and MET. This was combined with the third generation EGFR inhibitor lazertinib. And in the trial presented actually by Dr. Cho at ASCO, we saw a 36% response rate overall, and they did an analysis of whether patients had an acquired resistance mechanism driven by EGFR or MET. In that subset of patients, which was the minority of the 45 in the overall analysis, the response rate was 47%, compared with 29% response rate in patients who didn't have one of these mechanisms. So not clear that you would need or want to apply this selectively in just a subgroup of patients. And while this needs to be studied further, we're seeing response rates that give a lot of hope for something that could be done after patients have progressed on osimertinib, which is very helpful as a first-line therapy, but we know it doesn't last forever for patients. So more work needing to be done here, but there are other studies being planned. There's some other phase 2 data developing in the acquired resistance setting, but importantly, a trial called Mariposa, a phase 3 study that is looking at osimertinib as a standard arm versus either lazertinib as a single agent or the combination of amivantamab with lazertinib in the first line setting. That trial's ongoing, and that may change our practice in the coming years for patients with an EGFR mutation. And there was also a study presented just after that by Dr. Paseyane, number 9007, looked at Petrichomab deruxtecan. This is a HER3-directed antibody drug conjugate that showed a 39% response rate in patients who had received prior EGFR TKI, most of whom had received prior osimertinib, and same response rate there. There was no clear pattern of greater or lesser response rates with this agent, Petrichomab deruxtecan, regardless of the demonstrated mechanism of resistance. So we'll need to see more on that. But again, having more agents with potential utility in a setting where we just have not had data on what might be an option next, particularly targeted therapy options after osimertinib, very welcome news. But with that, we also got some studies showing the challenge of work predicated on good molecular testing. And one important study was by Nick Robert and colleagues. It was presented by Dr. Evangelist. Abstract 9004 looked at the US Oncology Network experience of the frequency of molecular testing in patients with stage 4 non-small cell lung cancer from spring of 2018 to spring of 2020. And what they found was, looking at rates of testing for PD-L1, EGFR ALK, ROS1, and BRAF V600E, while at least approximately 90% of patients had gotten testing for at least one of these over that time, only about 70 to 75% of patients had testing for the driver mutations like EGFR, ALK, ROS1, and less for BRAF V600E. So they did count PD-L1, which is really a different animal. And less than half the patients in this sample of almost 3,500 patients altogether had undergone testing for all 5 of these targets, which were not esoterica. These were targets that are in the NCCN guidelines with clear recommendations to do that testing, at least for non-squamous non-small cell, who were the majority of these patients. And there were FDA-approved therapies for all of these. So a little disappointing when we see that less than half of the patients are getting the full range of molecular testing. And when they looked specifically at NGS testing, they saw that while the numbers improved over the 2-year period, they only improved from 33% in the first 6 months to 45% getting NGS testing in the last 6-month period, which I would consider damning with faint praise. So I credit the investigators for taking a hard look in the mirror and asking about real-world experience of molecular testing. But it really shows us that we need to do better. We have all of these great targets, but we won't be able to avail ourselves of these therapies unless we do the testing that is needed. And some people wondered whether this was just a question of not looking well enough, or maybe detecting in a chart review what findings should be there. But in fact, Dr. Bruno and colleagues did a presentation just following that, abstract 9005, that looked at Flatiron data in more than 10,000 patients and saw that these patients with stage 4 non-small cell had a testing rate also of just under 50% overall for molecular markers. And just for good measure and adding insult to injury, we saw that from that data set, Black individuals had a significantly lower rate of molecular marker testing and about half the rate of participation in clinical trials. As we talk about equity in cancer care, it really underscores that we need to do better in molecular testing and racial diversity in testing and clinical trials. The final study that I wanted to highlight is of Almalertnib, another 3rd-generation EGFR inhibitor that was the subject of a trial called Aeneas. It was presented by Drs. Liu and colleagues in the poster discussion section for advanced non-small cell, obviously for advanced disease with an EGFR mutation, and comparing this agent Almalertnib to gefitinib, a 1st-generation EGFR inhibitor. This is very similar to the FLORA trial that led to our broad use of osimertinib first line instead of a 1st-generation EGFR inhibitor. This is a very similar trial compared to gefitinib, and this was a study done across China, 429 patients from 53 sites in China, that really recapitulated the improvement in progression-free survival. The difference here, 19.3-month median PFS with Almalertnib versus 9.9 months with gefitinib. So very good to see. The tolerability of Almalertnib seems pretty comparable to what we've come to expect and be very happy with for osimertinib. It's not a clearly superior result for efficacy or tolerability, but the hope is this is from a company that plans to bring this drug to market at a cost that's less than half that of osimertinib. Now, we don't yet have it commercially available, and we don't yet have data on CNS activity of Almalertnib, which is an important added feature for osimertinib, and we also don't have overall survival. But having the promise of an agent that could be disruptive and really break the détente, the impasse we have with prohibitively high drug pricing, this could make it possible to offer a drug like these third generation EGFR inhibitors, not just in places with a lot of money to spend on patient care, but in other parts of the world, and also with lower costs to patients in the US and Europe and elsewhere. So we need to see more on this, but this is, I believe, an agent to watch and an entire concept to watch. If we could come in with drugs that are comparable to what we already have, but have much lower prices associated with them. Obviously, that's a lot to cover, and it was a very exciting ASCO 21, but I think that we're going to have even more exciting things to follow as this research and other promising fields, areas move forward in the coming months and years. Thanks for your interest. Dr. Zilson and Bardia, thank you so much for your comments today on the most important findings in GI oncology and breast cancer from ASCO 2021, along with my own input on what's moving the field in lung cancer. Clearly, it's an exciting time in solid tumor oncology, as well as more broadly in hematology oncology. We'll have a lot more to cover in future programs. It's just an exciting time to be in the field.